So this year we've added some different talks based directly on your requests. And I hope that after this session, you'll give us feedback, what you really enjoyed and what you'd like to hear next year, because we're always changing it. And with great pleasure, I'd like to introduce Dr. Bryce Buckowitz, who's a neuro-ophthalmologist at the University of Florida. So she specialized in neurological conditions that affect the eyes and vision. And this is a talk that's been requested by members of our audience. So we're so grateful to have her with us. And I'll turn over the microphone to Dr. Buckowitz.
Hi, good morning. Thanks so much for the introduction. So thank you all for having me. I'm very excited to be here. As Dr. Melati said, I'm new faculty at the University of Florida. I just came in August of 2020, and I am a neuro-ophthalmologist, and I'll talk a little bit about what that is. I know it's a new term for a lot of you. And I originally, so I did my fellowship in Atlanta, so that's where I was recently coming from. And then before that, I was up in Connecticut at Yale doing a neurology residency. So my background is mainly in neurology with a specialty in ophthalmology. And so for this talk, I have no disclosures to report. And so what is neuroophthalmology? So I get this a lot where people haven't heard of the term, but basically it is a specialty that combines the neurologic disorders and vision. And what we do in neuroophthalmology is bridge the gap between neurology and ophthalmology. So we help with disorders that involve the brain and vision, and also try to figure out how the two go along with each other. So with a background in neurology and a specialty in ophthalmology, I see mostly diagnoses that involve the nerve of the eye and the brain. And so just to get a little bit technical to start with, a lot of you who have had Parkinson's disease likely know about some of why this occurs, and the pathogenesis is the word we use about dopamine. And so when you have a disease like Parkinson's, you lose dopamine, and specifically dopaminergic neurons, which are in a part of the brain that's called the substantia nigra or basal ganglia, which is in the middle of the brain. However, we also lose dopamine in the visual cortex, which is a major part of the brain that deals with processing vision. And then also we lose dopamine in the retina, which is a part of the eye that has our photoreceptors and records light and sends it to our nerve and to our brain. And so it's easy to see why dopamine plays a pretty important role in vision. And so it affects light adaptation, so going from a light room to a dark room or vice versa, contrast sensitivity, so something gray on a gray background, it's harder to see, eye movement, so moving your eyes, color vision, so just seeing color, and also what we call spatial working memory, which is navigating vision throughout space, understanding where you are, how far objects are from you. And so lack of dopamine can cause a variety of issues with vision. This is especially important because a lot of patients that have Parkinson's, especially those that have what we call the typical freezing gait, having difficulty initiating gait, use visual cues to overcome some of these symptoms. And so, as you can see in the picture, one of the symptoms that people have is the freezing gait, and they use tape on the ground to step over to initiate their gait. And so if you also have visual issues, this will be a little bit harder to do. And so visual cues certainly affect how people have good mobility. And if you have visual issues, this is often more difficult. So I found this educational supplement really helpful. And at the end of my talk, will have a list of all the resources for you guys to review. But this is from the American Parkinson's Disease Association, and they talk about neuroophthalmology and Parkinson's disease. And what they reported was about 75% of patients may have ocular motor signs, which means issues with moving the eyes around. And most patients actually have ophthalmic symptoms, so specific to eye issues, which include blurred vision, trouble reading, double vision, and dry eyes. Another study looked at ophthalmologic problems in Parkinson's disease, asking patients by doing a visual impairment questionnaire. What they found was that one or more ophthalmic symptoms were reported by up to 82% of patients, compared with 48% of patients that did not have Parkinson's disease. 68% of ophthalmic symptoms interfered with daily activities in patients with Parkinson's, compared to about 35% of controls. And what's really interesting is that about 80% of these issues are treatable. So it is important that we see what the issues are, diagnose it, and get someone to help treat them. So I am going to transition to basic eye disease. So this is stuff that the general ophthalmologist usually handles, or that you should be aware of. But in my practice, I deal with more the neurologic issues, which we'll get to later in the talk. But just so you get a background of other things that can be symptomatic, I'll talk about the eye disease first. And so one of the most common symptoms that patients with Parkinson's disease have, whether they have mild disease or severe disease, is dry eye. And so the way to look at dry eye, we have a few different ways to look at whether you blink enough or whether you have tear production that is sufficient. And so normal blink reflex is blinking 16 to 18 times per minute. In patients with Parkinson's disease, this can be about only 1 to 2 times per minute. So you can see how this could cause a lot of dryness in the eyes if you're not blinking your eyes and re-lubricating them as often as you need to. This can also lead to abnormal tear production. And often patients come in saying, well, I don't have dry eye because my eyes are tearing a lot. And usually if your eyes tear a lot, that can be a sign of dry eye because you're actually not producing the quality of tears that you need. So the tears are more watery and less lubricating. And so you can have abnormal tear production from dry eyes. So if you have dry eyes, this can cause several symptoms. Probably the most common is that you have some visual blurring. So if you let the eye dry out, the vision will get foggy after a few seconds or minutes. You can feel like there's a foreign body in your eye, so gritty sensation in your eye. And also this can cause double vision in each eye separately. So not the double vision that we talk about with alignment of the eyes, but double vision that we call monocular, meaning it's coming from just one eye. And that's because when the surface of the eye gets irregular or there's tear breakup areas, then you have light that scatters into the surface of the eye and it causes doubling of images. And so also dry eye can cause abnormal or excessive blinking. So the kind of opposite of when you start out not being able to blink often, you can actually have excessive blinking, and these are called lid spasms. So it looks like this, where someone's constantly blinking their eyes, and that can be essential blepharospasm. And so blepharospasm I'll talk about in a minute, but that can also be related to the dryness of the eyes. And dry eye is a constant issue and a constant battle for patients with Parkinson's disease. So it's something that you'll have to notice for, every eye visit you go to see how things are going, because it is a constant issue. So what do we do for dry eyes? The basic treatment starts with artificial tears. And we usually recommend preservative-free artificial tears. So the ones that come in the individual vial packs. These are preservative-free because you basically open them and use them once and then toss them. The ones in the bottle do have preservative, and so frequent use of those can cause some eye irritation, but usually any eye drops are better than none. And so we recommend use of about 4 times per day in each eye is something that should get you some relief. Nighttime eye ointment can be used as well to lubricate the eyes at night. However, this will cause blurry vision because the lubricant's pretty thick. And so when you wake up, you'll have blurry vision and you just need to kind of wash it out. And then for more severe cases, lid closure at night. Some people who have weak eyelid muscles might need some tape to close the eye at night so it prevents it from getting too dry. Or patients that wear CPAP or sleep apnea devices, they can often have a lot of blowing of the air into the eyes, and so that's something to look for as well. And so blepharospasm, or the abnormal blinking, the mainstay of therapy is Botox. And so this is the same Botox that you might know from, getting rid of wrinkles, injecting in the face. And what it does is it paralyzes the muscles. And so it prevents you from having that abnormal blinking or severe contraction of the eyelids. Another condition that's frequently seen in Parkinson's disease patients is called blepharitis. Blepharitis is when you have clogged eyelid glands, and you get this appearance of some crusting of the lashes here. And you can also have redness of the skin around the eyelid. And the reason this happens a lot in patients with Parkinson's is because they have autonomic dysfunction. And so this can certainly worsen dry eyes. So it's a good thing to check for. What we do for blepharitis is simple. We use warm compresses. So taking a washcloth, putting it in the microwave, putting it on your eye for 5 minutes a couple times a day, just to open up those glands. And then we also recommend lid scrubs. So taking a little bit of baby shampoo or mild soap and scrubbing your eyelids when you're in the shower or something similar. And so those should usually be enough to treat some of the blepharitis. And this in turn should help some of the dryness of the eyes. Moving on to the retina. So the retina is all of this orange part of the back of the eye. This is the part of the eye that sees the light, transmits the light to the optic nerve and to the brain. And so if there is decreased dopamine in the retina, it doesn't function as well, and there can be issues with decreased contrast sensitivity. So as I mentioned, when you have something gray on something gray, it's harder to see than something black on something white. And so you can also have color vision defects. So mostly what we've seen is it's on the blue-yellow scale, and that can also be because of the dopamine in the retina. And sometimes giving some dopamine can help this, but again, it's more of these subtle findings that aren't very well noticed. And there are some common age-related eye diseases that you should know about that aren't necessarily in patients with Parkinson's disease more than the general population, but because Parkinson's disease is usually later onset in life, you can run into some age-related eye disease that most people get as well. So it's important to differentiate that. The first is macular degeneration. So this is a fairly common disorder of the retina where you have little deposits, or what we call drusen, in the center of the retina where most of our vision is. This can cause decreased vision or distorted vision in kind of the middle of the eye, exactly what you're looking at. And so this can be very bothersome, and it can be a central blind spot. And so this needs evaluation and follow-up with a retina specialist or a general ophthalmologist, because they want to monitor you and make sure you're on the right supplementation vitamin-wise. And also they could help determine whether you're having severe issues from it or not. Sometimes if it does progress, they can do injections in the eye to help some of those symptoms. And for general eye health, what we recommend to prevent macular degeneration is good UV protection, so sunglasses when you're out in bright light, and then green leafy vegetables for good vitamins. And that's really what we have for prevention of macular degeneration. The other big thing that most people get, pretty much all people get once they get to their 70s or 80s, is cataracts. And so cataracts cause symptoms of what we call halos of light, seeing a ring around a light or distorted light, and nighttime glare. So headlights while driving being very glaring is a very common symptom, or very bright light at night. And this is because if you see here in the normal eye, this is the lens where light passes, and this is clear in a normal eye. But once we get to our 70s, 80s, the lens gets cloudy just because of normal aging, and it needs to be taken out for better vision. And when you have a cataract, you can also have blurry or cloudy vision. And the treatment is surgery. It's a small procedure that's probably 10 minutes by now. It's very easy to do for most surgeons. The eye ophthalmologists do it several times a week. They have a lot of experience, and usually you don't need anesthesia for this procedure. They do a local or a very light sedative, and it's something that most people get done at some point because of the symptoms that it causes. Now, moving on to more of the neurologic eye issues. So these are the things that I see in my clinic. These include mostly eye movements and double vision. To get you a little bit used to the terminology we use for eye movements, there are three main things that we talk about when we look at movements of the eye. The first is called saccadic eye movements. And this is when we use eye movements to look at one thing and then look at something else as if we're progressing on a page reading a sentence. So each word, going in between each word, would be a saccade. Pursuit eye movements is when, say, you're standing on the street and you're watching a car go by. You're stabilizing and fixating on one object and it moves along the road and your eyes smoothly watch that car go along. And then Convergence eye movements. These are eye movements where your eyes move together in a direction towards or away from something. And so I'll explain this a little bit further, but this is mostly what happens in patients with Parkinson's disease, is that they have problems with convergence that leads to double vision. And so for patients that have Parkinson's, saccades are slow or delayed. And so you can see that when you test it in clinic, they have difficulty initiating the movement of the eyes, and the saccades that they make are slower than normal. Sometimes patients need to blink to change position, and it can be hard to fixate on an object and read by tracking each word as you go along a page. Some of these symptoms can be improved with levodopa, and some of these symptoms are something that, using a ruler on a page or tracking with your finger can be helpful. In pursuit, patients with Parkinson's have jerky rather than smooth motion. So if you're looking at a car and you're seeing it go by smoothly, instead it's going to be jerky. So you're going to get a little bit of a different image going past. To give you an example, here's a sentence where the fixation point on this is on the word the, and each fixation is a word, but the saccade is what you do in between the words. So the brown is a saccade, brown fox is a saccade, and so on. And so you can see how if you have slow or impaired saccades, reading can be difficult. To explain convergence a little bit more, we talk about convergence with convergence or divergence. And so divergence is moving your eyes away from each other. Convergence is moving towards each other. And when you're looking at a distant object, you're looking pretty straight ahead. Your eyes are pretty much straight and you're able to see that one object in space far ahead of you. Your eyes are able to fixate on that. When we look up close, however, our eyes need to move inward. And so that's when you have a close object, so something that you're reading or looking up close at, and your eyes need to move inward and together to see that object, or else you'll have double vision. And this is commonly called accommodation, but we call it convergence when the eyes move in. Most people who are over 50 need reading glasses because of blurry vision up close. And so that can be one issue, but mostly it's actually the eyes moving inward. And so I'll show you more about that. If patients have difficulty with convergence, they can get eye strain, headache, or double vision at near. And in one study I was reading, about 20% of patients with Parkinson's disease experience some form of double vision, and that's what we call diplopia. The way that we measure this in clinic is looking at a near point of convergence. So if you can converge, meaning if you can look up close at about 10 centimeters, that's normal. If you can't look up close past 10 centimeters, you're still not able to see an object. We call that convergence insufficiency. So how do we treat this? What we use are prisms. And if you remember from maybe your high school science or chemistry courses, this is a object that bends light and sometimes can refract light or take the light waves and make it into a rainbow, if you've kind of heard of prisms before. What it does is it bends the light so that you have a different angle of where the light comes into your eye if you use it correctly. So to give you a better example of this, here is what your eyes will do when you're looking straight ahead. As we mentioned, your eyes are pretty straight. When you look up close, say you're reading, your eyes come together and they look at an object, and that creates single vision. When you have Parkinson's disease or some other neurodegenerative process and you're unable to converge, one eye is looking here, one eye is looking here, maybe one eye sees the target, the other doesn't. And so each eye is seeing a different visual field. And so you have two images basically, and you have double. Or if you're not able to do this comfortably, it causes a lot of eye strain and a lot of discomfort because you're really trying to get your eyes to look in. So what we do is we give you a small prism that bends the light toward the object, and it creates a single image with both eyes. And this is relatively easy to do. We do it in our clinic, and it can just be added to your eyeglass prescription. The other issue that I want to talk about briefly is visual spatial issues. And so these are more of the symptoms that are not as commonly diagnosed. These are the ones that they're a little bit harder to explain. They cause some impairment in functioning. And some of the things that people describe are problems with depth perception. So they are trying to reach for a glass on the table and they miss it, or they're too short, or they try to turn the sink on and they're too far away, or they're navigating a room, but they're bumping into objects like the couch or the table, and they never used to do that. And so these are visual spatial issues, or figuring out where we are in space and figuring out how far away an object is to us. And these can be difficult because if you're doing any fine motor tasks with both fingers, or say you need to connect a tube or connect a wire, you might miss it because you're just not able to perceive where each hand is in space and where that object is in space. And so it can be pretty frustrating, and it can be pretty hard to figure out what the problem is, because is it your vision? Is it that you can't see it well? Is it that you can't move your hands very well or can't figure out exactly how to do the task? Or is it something bigger in the brain and visual processing? This is probably the hardest issue to treat. And it's because this, again, there's no tool that we have right now to treat helping people navigate space. Sometimes the dopamine agents can help this, but what we usually recommend, or what I usually recommend to patients, is using other sensory stimuli. So say you're going to wash your hands at a sink and you want to make sure that you're up as close as you can to it, make sure you can feel the sink edge at your legs or at your stomach, and then you know you're close enough. Or using tools from occupational therapy to help you figure out ways to know where you are in space without relying on your vision. As humans, we rely on vision very much. And so it's very hard, especially when you have other issues, to not believe exactly what your visual input's telling you. And so these are things that adaptation is really the best thing to use for. But again, this is a very hard issue to treat. And one of the more underreported visual symptoms in patients that have Parkinson's or neurodegenerative issues are hallucinations. And so hallucination can be anything. It can be visual, it can be auditory, meaning a sound, it can be a sensation, but most of the time, In patients with neurodegenerative disease, we think about the visual hallucinations. This can be anything from seeing a person outside your window, inside your house, seeing an animal run across the room, seeing objects or movement of wallpaper on the wall that's not there. And in studies, I've seen up to about 60% of patients that have Parkinson's disease can develop hallucinations or even delusions. And we refer to this as Parkinson's disease psychosis. This is a hard thing for family members to understand, obviously, because it's something that the patient's experiencing and you can't exactly see it. But a lot of patients don't report these symptoms because of the stigma of having a, quote unquote, hallucination, or that something's going on and they don't want to express this to the family or want to be thought of as being, quote unquote, crazy. The thing with these hallucinations in most patients with Parkinson's is that they know that they're not real. And so they're not particularly, scary or bothersome. They're not the type of hallucinations that tell you what to do or tell you things. They're just things that you see. And so it's important that patients tell their healthcare provider or their family about these, because sometimes it's a medication effect. And so when you have too much dopamine, this can cause hallucinations. And so it can be as easy as a fix for decreasing the amount of medication you're on. And so even though it's a little bit unnerving to tell people that you're seeing things, it is a common thing in these patients. And so I recommend that people tell their healthcare provider about them. To treat hallucinations, it's a little bit of a different topic. And usually what we do is we can decrease the medication of the dopamine as much as tolerable, or there are other medications we can add to help decrease those symptoms. But again, adding medications usually has more side effects. And so it's a bigger conversation that I would have with the neurologist that you have to discuss what's best. And then lastly, there's just some other considerations that I always recommend to patients who are having difficulty with vision, but a lot of times single vision glasses are a good way to go. And what I mean by that is that you have one pair of glasses to read far away or one pair of glasses to look up close, and that you don't combine them into what's called a bifocal, where you have half of the glass is for distance and half is for near. The reason is because it's hard to move your eyes around and really understand where to look. And that can be very confusing, especially when you have issues with visual spatial representation or just moving your eyes the way that you want to. And so if you are to combine glasses, I do recommend a bifocal rather than a progressive lens. Sometimes when you have that line, it's easier to know where to look. When you have a progressive, it may be a little bit harder to know exactly, what your focus point is. And so that's usually very helpful in certain patients. And so if you are having difficulty with your glasses, that is one thing to talk about with your eye care provider. I have this table in here because I thought it would be helpful for you all to reference, but this was in one of the journals that I was reading. And so this can be really helpful for you to look over and say, okay, do I have any of these symptoms? If I do, who do I see and what are they going to recommend? And so a lot of this, so just to go through some of the ocular surface disease that we had talked about, do you have sore, watery, or red eyes? Do you have blurry vision when you're looking up close? Do you have a burning or sandy feeling? So these are the things that we mentioned, and the screening test will be to look at those parts of the eye. And so this is helpful for, I think, you as the patient to look at just to see if you need any of these looked at. And if not, that's fine. A lot of eye doctors, knowing your history of having Parkinson's disease, will look for these anyway. The main things, again, that a general eye doctor or ophthalmologist will look at are these ocular surface issues. So if you have any of these ocular surface issues, a general eye doctor is well equipped to handle these, as well as anything with kind of the retina or optic nerve. But again, the double vision, the issues with reading up close and having difficulty with that, even having a good prescription, that's a lot of what I see. And that's just because it's a bit more complex than the regular eye exam. And so I have a list of all the resources that I have from my talk. And so if you are interested in learning more, there are some good resources in here to help. One of the ones that I mentioned earlier that's very easy to read was, let me see where it went. This one here, number 6, NeuroOphthalmology and Parkinson's Disease, American Parkinson's Disease Association. And this is an educational supplement, and it also basically gives you a sense of my talk today into different categories of vision if you're interested in learning more. And so I won't be able to make the session this afternoon for the Q&A, so I left plenty of time today to have a conversation and talk to you guys about any questions you might have about what I do or what I see, or any visual issues that you have, or questions about my talk. I will say that I'm more than happy to see anyone in my clinic for any of these issues. And just with a disclaimer that I do currently book out probably till June or July right now, but that should change. I should have more time and I'll always get to you, but it might be a little bit of a wait. All right. So let me open up the Q&A. Okay. So the first question here, there is some recent attention to herbicide exposure as it may relate to Parkinson's. Do you see any progress towards home insecticide regulation and well water contamination contributing to Parkinson's? So
sorry. I'm sorry. I was going to say, if you see a question that's not neuroophthalmological, you're welcome to leave that for the general session at the end. But if you're comfortable answering it, that's just totally fantastic.
No problem. Yeah, I was going to say, I think that's a little outside of my range of knowledge in terms of herbicide exposure, but it is an interesting question. And well water contamination is something that I check for in certain patients that have optic nerve disorders. But again, in general Parkinson's, I'll leave that to more of the other neurology specialists. So does the doctor need a referral to be seen? Usually it depends on your insurance. And a lot of times it's just through your primary care doctor. But if you see neurology here at UF, they often send me consultations and I can see you and put you in the schedule that way. All right. And is it easy to discern between pollen allergies and dry eye issues? So that's a good question. So it can. Pollen allergies usually have specific eyelid changes, so inner eyelid changes that are classified into different types of reactions. So an allergy can be different from dry eyes. And so any general ophthalmologist will be able to distinguish between the two. Often there's a component of both. And so that would just need to be treated a little differently, but yes. Does Parkinson's affect peripheral vision? So yeah, that's a good question. Parkinson's disease can affect peripheral vision. What we see is that there is a lot of overlap in some neurodegenerative conditions. One condition called posterior cortical atrophy is a neurodegeneration of the visual part of the brain, more so than other parts. And in those patients, you can have visual field issues where you have decreased peripheral vision and other changes in vision. And so that is something I look at when patients have Parkinson's, because if they do have a neurodegenerative condition that's similar or has Parkinson-like features, it often can be missed. And so most patients that have Parkinson's don't have too much of a visual or peripheral vision issue, I will say, just by experience. All right, so next question I'm going to read. I'm about to make an appointment for my husband's yearly eye exam. His longtime doctor just retired, so he will be seeing a new doctor. Because we live near Gainesville, I'm wondering if you wouldn't be a wiser option to come to you. I'm surprised at how many things you discuss in your presentation are things we are experiencing. And so I think that's fine. If I can certainly do a lot of a general eye exam, although I am neurology trained, I am not as versed in general eye issues, but I can certainly see someone for Parkinson's related issues. And then if there is an issue that I'm not comfortable with in terms of, severe dry eye treatment, or they need cataract surgery, we have plenty of people in our clinic that can do that. And so I would just have you see them as well. But I would be happy to see somebody just for, the first time Parkinson's related exam, check for a few of the things that I mentioned in my talk and make sure that none of those are a big issue or affecting you. All right. Please discuss the relationship between blurred vision and dry eyes with aging in all patients. It sounds like the use of warm compresses and lid scrub is a first line easy treatments. Yeah. So blurred vision is a very difficult complaint because anything can cause blurred vision. So it can be anything from needing glasses, having dryness of the eyes, having blepharitis, actually having poor vision, having color vision issues. All of these things people can describe as being blurred vision, or even double vision is often referred to as blurred. And so with dry eyes, it's mostly using the artificial tears, sometimes using the nighttime ointments, definitely doing warm compresses and lid scrubs. That's a very good one. The difference, if you know that you have dryness of the eyes, you often might have a little bit of eye pain, a little bit of that gritty sensation. And some people don't have many symptoms of dry eyes. So the best thing to do is just check in with your local eye doctor and say, hey, I'm having some blurred vision. I think my eyes might be dry. What would you recommend? And they would be more than happy to go through kind of a basic exam for that. Okay. So next question, I developed blurred and double vision and dizziness when playing golf, walking on undeveloped surfaces, head up and down when teeing a ball or picking it up. It can happen after a hard workout where I ended my exercise with hard boxing. Again, head up and down in quick movements. Solution, how do I address? So that is a very common complaint. This is a difficult thing to work with. I think the double vision, that's something that we can evaluate in clinic. And what we do is look at different directions of gaze and looking for any misalignment of the eyes, which can also happen for distance as well as looking up close. The dizziness part is also hard because vision and what we call vestibular disorders, or kind of the things that are in the inner ear that cause dizziness, are very closely related. And so when you move your head up and down, you're using a lot of different things. You're using your eye movements, you're using your inner ears to figure out where your head is and where to look. And so it's a lot for your brain to process all at once. And if it happens after you're exercising, boxing, moving around quickly, it might be also an inner ear issue. How do we address this is really by looking for things on examination, looking for any visual issues first, if you're actually having double vision, or if the problem is more of an inner ear balance issue. And the up and down quick head movements are difficult for patients with Parkinson's because of the things I mentioned with, the eye movements, the pursuits, the jerking of that. And so there's not a great solution, I will say. I think the biggest solution is what you're already doing, is keep being active and keep working on that. Sometimes a physical therapist for vestibular therapy can help that, but there are some common issues that cause dizziness that can be treated with an ear, nose, and throat, or your neurologist can look for those. And so sometimes it's just about eliminating things and going through your doctors to see. All right. Could light therapy at specific nanometers be helpful with dopagenic production in the eyes? That's an interesting question. I don't know, to be honest. I haven't seen any specific data to say that produces more dopamine. Theoretically, it could, but in my practice, I don't have the knowledge of the retina to say for sure what that would be. So if you're interested in that, there are some resources you can look at to see what kind of studies they're doing. As far as I know, at least for clinic and what we have available for us, we don't have any therapies like that right now, but I think it's an interesting idea, and it's probably something that could come up in the future. All right. Are Parkinson's patients more susceptible to strokes in the eye? So that's a great question. I would say no, actually. So strokes in the eye can be caused from heart issues, high blood pressure, having too much cholesterol, those type of things, or smoking. And usually if you're talking about a stroke in the eye where you have a little blood clot that comes into the eye, that you shouldn't be at more risk for having Parkinson's, because Parkinson's shouldn't cause too much of an increased vascular risk compared to other neurodegenerative or just aging issues. In my experience, I haven't seen any correlation that patients have more severe issues with strokes in the eyes rather than the general population. Okay. And so eye level surfaces. So I'm not exactly sure what that is. I would like, if you don't mind explaining that, I'd be happy to answer. All right. And then from Rachel Dorsey, so thank you for your talk. Would you mind addressing the impact for people with Parkinson's disease of the newer Monovision option for cataract surgery correction? So that's a great question. So Monovision is when one eye sees for far away and one eye sees up close. And they use that for patients that may have what's called myopia, or they have their whole life they had difficulty seeing far away. And then as we get older, we need reading glasses at age 40 or 50. And then you're stuck with two glasses, one for looking up close and one for far away. And when you do cataract surgery, you can correct someone's prescription because you are putting in an artificial lens, which is basically like having an eyeglass refraction or an eyeglass inside your eye. So it fixes your vision. And what they do is they fix one eye for a distance prescription and one eye for a near prescription. I would not recommend this for patients with Parkinson's disease because, first, probably only a third of people can do monovision regardless of what medical conditions they have. So, for instance, I tried to do monovision for contact lenses and my brain couldn't adapt to it. So I wore one contact lens for far away and one I didn't wear, and I just wanted to see if my brain could just look at one image. And I couldn't do it after a few weeks. And so probably only about a third of people have the ability to do monovision because it requires you to ignore one image at a time. If you're looking far away, you're seeing one blurry image and one clear image. And if you're looking up close, you're seeing one blurry and one clear. And the idea is that if you can adapt and ignore the blurry vision part of your eye, you can see clear for far and near. But again, in the ideal person, that only really works in certain patients. And in patients that have Parkinson's disease, that's probably a little too much for your visual processing ability. And the problem is once it's in, they can't really fix it after that. So they can't take it out and put a new one in without causing serious complications. Okay. Since switching over to Cinemet to Rytary, I have noticed that my vision is blurry. Any experience with this? And if so, what might be causing this? Yeah, so that's a good question. In my experience, it's hard to know exactly, whether it's the dose of dopamine, the release of dopamine, what you're used to, whether you're having changes based on how much dopamine you're having in your system at that time. Because I mentioned that blurry vision is a very hard complaint to kind of pinpoint, I would say that it's hard to say what part of your vision is causing you to have blurry vision, whether it's something that's not related to the med that we can look at that's just coincidental to the switch. That may be it too. But in my experience, switching medications may have more to do with some of the other neurologic symptoms of vision than just the blurring or the dryness of the eyes. And so that would be something I would probably just look at in clinic. I can't say for sure certain medications cause blurry vision more than others, but I think everyone is very specific in what they react to with different medications and doses. So if you went back to Cinemet and you liked that better or didn't have blurry vision, then yes, I would say maybe there is a connection. But if the Rytary is helping with more than just the vision, we could look at some of the visual issues you're having and maybe correct those without changing the medication. So it's a personal choice, but that's something that I would recommend. Okay.
Dr. Buckowitz, this is Irene. I have a question.
Sure.
When some people with Parkinson's have convergence insufficiency, where it's hard to adjust their eyes to look at things close up when they've been looking at things far away, do you think that exercises, we've heard of exercises of being instructed to look at a pencil and move it slowly closer and that kind of things. Do you think those help? Can you exercise that into improvement, or is that something that if a person has that issue, exercises are not so helpful?
Yeah, no, that's a great question. I think that comes up a lot. I think it can be helpful, but again, it's patient specific and it depends on how bad the issue is or how long they've had it. If a patient is having just eye strain, some of those symptoms where it's not quite, they can still look up close, they can still read okay. I think those are the patients that maybe doing some of those therapies are the best and helpful for, because it can kind of keep them going with that exercise. In studies that I've seen, there hasn't been a clear positive correlation with doing that and helping the convergence issues. But I don't think it hurts at all. I think it's just depending on how bad the patient's disease is. So if a patient has had this for many years, it's just never been explored, they've stopped reading because they can't deal with it, those are the patients I would just put a prism in and not worry about the kind of what we call pencil push-ups or things like that. But it doesn't hurt. It's not going to cause any, worsening of vision or eye strain. It's just, it can be something we can use, but probably in the more mild disease patients, I would recommend it.
Thank you. And for the audience, you mentioned at some point that vestibular therapy may have a role for some people's issues. And I just wanted to say we do have that at the Fixell Institute. One of our therapists is trained in vestibular rehab, so it's good to know it's available.
Yeah, I think that's always a really helpful tool. And so I think someone just asked, if a PD patient goes to physical therapist for vision and balance, do they need to specialize in Parkinson's? That's a good question. I would actually leave to the other panelists to say what you think in terms of, your experience with other therapists that aren't specialized in PD. So I'll let them answer that whenever they will.
I can make a small comment on that. I think it's similar to having an expert, having the great luxury we have of having a neuroophthalmologist. I think the more specialized practitioner is, the more in tune they are with the kinds of problems that you have, and maybe the most recent literature, meaning the most recent studies that have come out on the most modern techniques. Similarly, if you have Parkinson's, seeing a neurologist probably will offer you more expertise than just your general doctor, and seeing a movement disorder expert is certainly going to have more expertise in the difficulties in more complicated or advanced Parkinson's. Well, therapists, any therapy is better than not getting therapy. And if you're able to access someone who's a specialist in Parkinson's, of course, this is going to be a little bit better than someone who sees mostly broken limbs or tendon strains. So the more specialized, the better. But if you don't have that in your area, it's better to see somebody who you can see regularly than anyone else. And sometimes what works, many of the people who come see us at our center live far away and may not have Parkinson expert therapists like we do. So sometimes if you can see an expert therapist even twice a year, they can send recommendations to the therapist in your community. And so that's a model that we've used that's been real helpful for people who don't live close enough that they can come once a week, is they can get a printing of instructions sent to a local therapist to give them advice.
All right. Any last questions? Anything else? And I think just to mention I think the presentation, or at least the recorded presentation, will be available later on, so you guys can also review specific topics or anything else that you were thinking of that you didn't have a chance to ask. But again, I'm available at the UF Eye Center, and so I'm happy to see you all. Anything else? Can you briefly speak on the role of visual fatigue? So that's a great question. It comes up pretty commonly. Visual fatigue, again, it's just like any other type of fatigue. So cognitive fatigue, physical fatigue, anything else. It's something that I think can happen when, one, your vision is not as good as it should be. So if you need a new pair of glasses, or if your vision's a bit blurred, you can get a little bit fatigued by just trying to kind of focus on something that you're not seeing very well. A lot of times it can happen in patients that read because they just have either convergence issues, and so they get fatigued because they're using their muscles so hard and they don't have the same ability to do it as easily anymore. And so that can cause fatigue. And so a lot of people say, I just don't like reading anymore. It's uncomfortable. I'm not sure why, but I stopped reading. I don't like to read. And I think that is a big part of visual fatigue as well, is that, some of the things that patients just aren't aware of that they're doing is just because they're just not able to do that as easily. And so I think visual fatigue, just like I was mentioning, anything else like cognitive fatigue, they all go together. So, for example, patients that have migraines or other type of neurologic diseases have worsening vision during a migraine when they're having, kind of that headache, the pain syndrome, and your vision can get blurry. It can be double, it can be worse. So anything that affects the whole brain, if you're tired, if you're, not in the right, time of day for your medication, those can all make your vision worse just because of your brain. And so it's just interesting that, it can be a very diffuse issue. All right. Thank you guys for having me.